more MDs have to become more aware of the business aspect of being a surgeon.
1,000%. Vascular surgeons are very valuable to hospitals. You still have to understand the business of what you're doing. Hospital collected on average $20 to $30 per RVU on the physician professional component. On the facility or hospital component, they collected $300 to $400 an RVU. Once that's your contract, it is what it is.
Today we have the privilege of sitting down with Dr. Michael Wilderman.
You want to be happy where you go. You want to like the people you work with. You don't want to worry that you didn't answer that phone fast enough, so they called 3 people and now 4 people are running to the door. And that's regardless of employed or not employed.
Hey everybody, thank you for tuning in for our episode today. As you know, we're doing these small microfilms highlighting MDs throughout the United States that are doing excellent work. And today we have the privilege of sitting down with Dr. Michael Wilderman. He brings a wealth of experience, and I just wanted everybody to get to know him and just kind of learn a little bit of background about him. Because as you know, we work with doctors from all over the country, and man, these guys are doing excellent work, but we never get to see what's behind closed doors outside of the procedures or the treatments, or whether or not you're seeing them on a podium giving some public speaking announcement about a procedure or a treatment option that's available for us to all benefit from. So thank you for joining us, Michael.
Thank you for having me today.
You know, let's just kind of start with this. What inspired you to get into medicine? Was there anybody specific that inspired you?
Sure. So my father was in medicine, and so he was a perfect idol for me to look up to and role model. And I loved the sciences behind medicine. And ultimately, I chose surgery as a field rather than others because I actually liked actively taking care of patients as opposed to coming up with a treatment plan, but then letting medicines do the work.
Okay, so let's get into it, Michael. What's the issue with the RVU model?
The only issue with the RVU model is trying to negotiate a reasonable amount of RVUs. I gave a talk last year on the business of vascular surgery at our national meeting. And on average, the professional fees of a procedure, doctors got collected, if they only got paid, this wasn't the number they got paid, but the hospital collected on average $20 to $30 per RVU on the physician professional component. On the facility or hospital component, they collected $300 to $400 an RVU. And they're paying doctors $60, $70, $80 an RVU. So it's better than the professional, but they're still raking it in. But that's the model that whether you work at Mount Sinai, whether you're employed by Hackensack, you get paid on RVUs. So all you care about is how many RVUs that case had. The other thing which we've seen, unfortunately, if the hospital does a bad job collecting, you could say, look, this quarter I did whatever, 5,000 RVUs, you're paying me $100 an RVU. I'm just making it up, but I want my 500,000 RVUs. My $500,000. If you do 5,000 RVUs at $100, it's $500,000. I want my 500. Well, you know, we really appreciate it, but we only collected 270. That's not my problem. If the deal is I signed up for RVUs, your problem is figuring out how to collect. My problem is providing the service. But they've done that too. They say, sorry, we didn't collect, we're not paying.
Isn't it, you get more if the case is more complex, right?
No. You get more RVUs,
yeah,
but you get a fixed number per RVU.
How negotiable is that?
Well, you get a contract, but the way you do it is sometimes they just say, we're gonna pay you $100 an RVU, whether you do 1 RVU or 1,000,000. Or they say, for the first 5,000, we'll pay you 50, for the next 5,000, we'll pay you 60, for the next 5,000, we'll pay you 70. However, there's different ways, but once that's your contract, it is what it is. You know, there are people who can sit in their office and generate more RVUs in a day than I could doing a 6-hour operation. That's a one-off operation. And maybe it gets 80 RVUs, I'm making it up, but maybe it gets 80 RVUs, but you may be able to do 5 RVUs per patient, see a lot of patients, and order some tests and whatever else. That's the RVU model. And I'm not saying it's a good one, but what it creates is you don't think about any business. You're not worrying about your secretary and your coordinator and your medical assistant and your PA. It's all your RVUs. So for people who have huge overhead practices, 20 employees and nurses and techs and all, they don't have to think about that. Whoever entity Mount Sinai, if they're affiliated with Mount Sinai, they cover all that. And then they pay the doctors a certain amount per RVU. Now that number may factor in how much overhead, how much you generate, all that. But that's how that game is played, and it's not necessarily a good one, but they don't have to think about any business.
Like when you said that you did a presentation about the business of vascular surgery, what's that look like?
Vascular surgeons are very valuable to hospitals, to outpatient procedure places such as outpatient labs or ambulatory surgery centers. Vascular surgeons are needed across multiple areas. One, vascular surgery generates large charges and collections for institutions. The patients are older and sicker, and the operations are more complicated, so that generates higher case mix indexes, which leads to better reimbursements for hospitals. Two is many of the other specialties require vascular surgery. We get asked to help surgical oncologists, urologists, spine surgeons, elective operations that they can't do without us helping move blood vessels, protect blood vessels, things like that. That increases the case mix index for other providers. We're sort of the fixer of bleeding complications in cardiology, in radiology, in trauma. So we get called for that. So those services, you need a vascular surgeon. You need a vascular surgeon more than you need a heart surgeon, because there are hospitals that still have patients show up with bleeding and still have patients show up with tumors and things like that. And the hospital may say, we're not going to do heart surgery, open heart surgery, but we need vascular surgeons to do those other kinds of procedures. And so that's on the inpatient side, aside from all the diagnostic testing that we may order or vascular tests that we read for the hospital. So vascular surgeons can generate a lot of bottom line for a hospital. Sometimes it's the highest as far as specialties. Certainly it's in the top 3 or 4 in every hospital, depending. Certainly if you have very proficient, experienced vascular surgeons, you can do a lot more complicated kinds of operations, especially on urgent, emergent situations like blood clots to the lungs that we have to go fix, complicated aneurysms, strokes, things like that. And so vascular surgeons are very valuable for hospitals. Many of the high volume procedures that can generate a lot of money can be done in outpatient procedure places. And so you can do more high throughput and still generate high fees for a surgery center. And if the hospital owns a surgery center or a business owns the surgery center, it's very productive for vascular surgery. And that's regardless of employed or not employed.
That's what I was going to ask you.
That has nothing, that's a collections. So who does the collecting, whether you're a university or academic center, whether you're a large health network, whether you're a private entity, there's potential for high collections. It's just how well is your institution with contracts and collecting revenue. But vascular surgeons are very valuable for institutions.
More and more MDs have to become aware of the business aspect of being a surgeon.
1,000%. And in the last few years, we've seen more, whether it's a session, meaning multiple talks at a national meeting, or one large talk, longer talk, at a national meeting, they're starting to get the word out, because regardless of where you work, you still have to understand the business of what you're doing. So if you're in an employed model, unless you're just getting a salary, then you still have to understand the varying concepts that are contributing to your salary. And even if you're just getting a salary, if you know that this is what the hospital's collecting, then you can negotiate a better salary at a different time. And if you're in more of a entrepreneurial private practice or other service agreements, then yes, you have to understand the business of medicine, regardless of what kind of procedures you do. There's no formal teaching, but gradually through residency and fellowships, you start to learn. And while it may not be comfortable for somebody to ask, well, what do you make, or how do you can certainly ask about the concepts. And I think it's also incumbent upon trainees, as they're getting ready to pick jobs, to ask their mentors, friends. Here's what this kind of contract is. This is the job structure. What do you think?
It's okay to negotiate.
Yeah, and just ask. I mean, you don't have to tell me or ask me what I make, but you could show me the contract and the framework, and I could tell you that that's good or bad. This would be my concerns, things that were almost forbidden to ask 20 years ago. And so I think it's all important. Nobody wants to go into this and shouldn't go into this for the money, but you might as well be able to maximize your earning potential doing the same job that you can.
Yeah, and when you go teach at these associations, vascular associations, do you see more and more that the younger generations are coming up with this type of knowledge, or is it still, hit and miss?
No, I think the people ask. It depends. Now people talk about how many RVUs they do, or how many. Nobody says, "Oh, I did 400 cases last year," or "I did 20 aneurysms." They'll say, "I do this many RVUs or things." I think the one thing that people have started to realize, if they become employed at either a large, so first of all, I think the lines between academics and private practice are blending a lot more. So I think I look at it as sort of more of, are you employed or are you self-employed? And even if you're employed by a large entity, most physicians that I know have a single contract with the institution. It's not a group contract. So the more they do, the more they make. There's not a lot of sharing and partners and things like that. And it's more of a eat what you kill model, which could be good if you're hungry and work hard. You're just basically an individual provider with maybe some shared overhead and maybe some coverage. And if you don't have coverage from partners, you may have coverage through the residents or fellows or trainees, but you're really just your own individual provider with the business.
What's the path of least resistance, though?
I think at the end of the day, you have to decide what's important for you.
Yeah.
And I think you want to be happy where you go. You want to like the people you work with. You don't want to worry that you didn't answer that phone fast enough, so they called 3 people, and now 4 people are running to the door to see that patient, fighting over the whatever. And some people want to be or need validation or fame or a certain institution behind them to make them either feel better or think they'll do a better job. Others don't care.
Yeah, and we're all going to have to adapt to market forces, market trends, the macroeconomics of the whole experience. Once again, thank you, Dr. Wilderman.
Oh, my pleasure.
Yeah, for sitting down with us. Again, thanks guys for joining us in our conversation today. I hope you gained something out of this, and we look forward to reaching you at another one of these films with these amazing MDs. Thank you very much.